Good afternoon to everyone, Mr. Chairman, Mrs. Chairman, thank you very much for the invitation. This is the title of my talk, The Importance of Nocturnal Monitoring of NIV. These are my conflict of interest. And the first problem that I want to deal is a very simple question. What does happen during the night to our breathing? Now, it has been shown several times, this is one of the first papers, this is the reason why I show you now. They demonstrate that when you are affected by different pathology, your minute ventilation goes down during the nighttime, and the most profound variation are obviously done during REM sleep, both in COPD, obesity, hyperventilation syndrome, and other disorder. Please remind, this is very simple, that minute ventilation means tidal volume times breathing frequency. Well, let's see from this trace what happened to tidal volume and breathing frequency. Well, during nighttime, especially during REM sleep, tidal volume goes down, and breathing frequency goes a little bit up. Remember that together with a reduction in minute ventilation, sometime in this patient also oxygen saturation drops dramatically. And this, as I said before, is mainly due to this important reduction in tidal volume. Well, why this happened? Because we know for the physiology that respiratory muscle activity deeply changes during the nighttime and especially during REM sleep. Because during this phase of this stage of sleep better, phasic activity of intercostal muscle is reduced, the tonic activity of the same muscle is abolished, while what happened to the diaphragm is that the tonic activity is abolished. Why? The phasic activity is increased. And this may explain why breathing frequency goes a little bit up, but especially tidal volume goes dramatically down. Well, during nighttime, we may face other physiological problems. Maybe, for example, the ventilatory response to carbon dioxide change, because what the physiology calls the set point, that is the partial pressure of CO2 at which ventilation begins to increase, during sleep is usually a higher PaCO2 than during wakefulness. And the slope of the linear relationship between ventilation and PaCO2 is for this reason decreased. And this holds particularly true when you are affected by a chronic respiratory disorder. For example, if you are a stable COPD and you go to the REM sleep, not only you will observe a drop in oxygen saturation, but also, as you can clearly see here, you may see a dramatic rise in transcutaneous CO2 recording. Well, why do we need to monitor home ventilation? We know that the large majority, if not all the patients undergoing home mechanical ventilation, they are ventilated during nighttime. And since we saw that during nighttime you got a dramatic change in our breathing pattern, in our respiratory drive, it is very important to see how the patient reacts to the application of mechanical ventilation. But the first thing to take into consideration is the adherence to therapy. If you don't take a medication or you take in a wrong way, the medication is not going to work. So you need to check if your medication, in this case, your ventilation is working during nighttime or not. Well, we already know from the literature that at least in obese COPD patients, there is a high risk of hospital readmission if you ventilate less than 4 hours a night. And the risk of readmission decreases dramatically if you ventilate for a longer period of time. Why this? Because, for example, you can correct much better the gas exchange. In this nice study, they were looking the hours of daily use on this x-axis, and here is the changes in transcutaneous CO2. And you see that the more you use the ventilator at night, the more you decrease your PaCO2. But from a clinical point of view, when some authors split retrospectively the patient in those that they call adherent patient to the non-adherent patient, that means the adherent patient slept at least 6 hours under mechanical ventilation versus those patients who did not sleep more than 6 hours under mechanical ventilation, there was a clear and statistically significant higher percentage of patients that did not require hospital readmission. Well, in patients with other disease like amyotrophic lateral sclerosis, other people, they show something that was more dramatic, was not only hospital readmission, but survival rate. In this study, it was extremely clear that if you are not compliant to non-invasive ventilation, your survival rate at 1 year is much lower than those patients who receive an adequate hour of home mechanical ventilation. So compliance and tolerance to treatment is extremely important also to assess the outcome of our patient. Well, there is a very nice graphic way to assess the usage of our patient. I mean, this is quite impressive because this is a period from July 15 till the end of the year, and you can have immediately a snapshot, first of all, of the usage of hours of mechanical ventilation during nighttime, and then also see if they somehow change the mode of ventilation, if they increase or decrease tidal volume. So I think this is a very nice graphic panel to just understand better how our patient is doing. And you can see not only the few days before, but you can also see a very large number of months or days. Well, the other thing that is extremely important to monitor during home mechanical ventilation is the efficacy of the therapy, obviously. And one of the ways to see if therapy is working is if NIV is able to improve gas exchange. Well, let's start with the easiest one, by pulse oximetry. But pulse oximetry has a lot of advantage, low cost, easy to use, and to make some basic interpretation. Is it possible to connect it to ventilation? Is it possible to use in telemedicine? So pulse oximetry is simple, but it has a lot of advantages. Well, it has also some limitation. As you know better, probably than I do from the physiology, due to the shape of the hemoglobin dissociation curve, its sensitivity can be poor when the patient has a normal daytime PaO2, as only a significant drop in PaO2 will result in a drop of oxygen saturation. But this holds even more important if the patient receives supplemental oxygen during non-invasive ventilation, as hypoxemia associated with hypoventilation, in this case, can be masked. So these are theoretical limitations, but I think the most important limitation is this one that I'm trying to show you. So oxygen saturation may be extremely useful to detect a problem of ventilation, a drop in saturation, but not really informative about the mechanism. Here, for example, you can have desaturation because there is a decrease of ventilatory command. We will see later on the practical part. In this case, you can have residual obstructive event, and here, for example, you can have problem of leaks. So saturation is a very powerful signal to detect that there is a problem, but then it's not so informative to detect the mechanism of the problem. Well, and then this is the classical home ventilator in which we can more or less see together with tidal volume, usually in the display, the pressure and the flow trace. Well, I do not think these two signals are enough to depict what I said in the previous slide. So you will hear today, later on, the importance of the abdominal and thoracic belts that may add a lot on the mechanism of nocturnal hypoventilation and possible hypoxia. Well, what's about the monitoring of CO2? We were talking about gas exchange. Gas exchange is not only oxygen, but it's also CO2. I start with limitations because the transcutaneous CO2 can give us a lot of useful information. The counterpart is that this device requires periodic recalibration and change of membrane in order to ensure sufficient precision of transcutaneous measurement. Although this is important to say, this limitation has been greatly improved in recent devices. So you know what I'm talking about. I don't want to have any commercial spot. However, you should know exactly how your device is working. Some of them are very reliable, some other are a little bit less. The other problem is that transcutaneous CO2 sensor may drift during the nighttime, and so you need also to consider the potential problem. What has been also proposed is end-tidal CO2. But we know that measurement of the gas exchange with end-tidal CO2 is particularly tricky in patients with hypercapnia. Why? Because the relationship between the real arterial PaCO2 and the end-tidal CO2 depends mainly on the physiological death space and the patient ventilatory mode. Nothing wrong, but we know that in most of the patients undergoing non-invasive ventilation, this is not homogeneous, and expired CO2 does not reach an adequate plateau to be considered reliable. And therefore, I am a little bit skeptical about the use of end-tidal CO2 to monitor gas exchange. Well, the last part is efficacy of the therapy. That means, how can I monitor ventilation? We saw in the first slide that ventilation means an adequate recording of breathing frequency, easy, apparently easy, if you don't have gross patient ventilation interaction anomalies. And on the other side, you need to record tidal volume. I want to spend 1 second on tidal volume. The recording of tidal volume depends deeply on the type of ventilator circuit that you have. You know that you may have, as in ICU ventilator, a double link circuit with intentional leaks in non-vented circuit, or a single limb with intentional leaks, what we call vented circuit. Then we may have a single link circuit with non-intentional leak that is called also roughly non-vented circuit. I try to explain a little bit better what I mean for this. The take-home message here, the tidal volume can be measured in a double tube system if you have 2 pneumotac, for example, can be estimated in a single limb circuit with non-intentional leak and with intentional leak. But the difference between these two in estimated tidal volume is really huge. Well, let's see how it works. This is the leak management in what we call non-vented circuit, what we call also the expiratory valve. Like you have a valve in the expiratory on the single limb that allowed a washout of air during expiration. Well, non-intentional leaks in this approach is computed at the beginning of inspiration and is not considered as baseline. Extra leak is considered as part of the delivering the tidal volume. Therefore, the higher the leaks, the higher is inspired tidal volume, and the lower is expired tidal volume. In other words, if you increase the leaks, it's clear that expired tidal volume decrease while you got higher inspired tidal volume. And the ventilator is not able to depict the difference between what you receive and what you should receive and what you really get. Now, a much more reliable system to estimate tidal volume is what we call the leak management in a vented circuit. You have here what we call a non-rebreathing circuit. It can be a different device according to the different ventilator, but it's not a real expiratory valve. Intentional leaks in this setting is computed at the end of expiration and considered in this case as baseline. Overall leaks, that mean intentional leaks, you know how much is it, plus extra leaks, what we are called non-intentional leak, are also measured at the beginning of inspiration by using certain algorithms according to the ventilator. Extra leaks is not considered as part of the delivered tidal volume. The estimated inspired tidal volume should remain constant in the presence of a linear non-intentional leaks. And therefore, the measurement of actually the estimation of tidal volume in a vented circuit theoretically should be much better than in non-vented circuit. This is a classical example. This is a very nice study by Annalisa Carlucci. On the blue line, you see the display of the tidal volume measured by the ventilator, and here is the real expired tidal volume. Everything is fine if there is no leaks, but if you apply a leaks, you know the ventilator keep reading a very high tidal volume, but as a matter of fact, expiratory tidal volume decrease. And once you stop the leaks, well, the situation comes back to normal. This is because in these three different ventilators, the setting was a classical non-vented circuit. So the take-home message is that in the presence of non-intentional leaks, tidal volume increases in non-vented configuration and exhale tidal volume decreases, obviously. Well, the other point that I want to make very briefly, run out of time, concerning the efficacy on therapy is the pickup of leaks. I think nowadays we have, this is a screen by Brea's ventilator in which there is a very nice view of what is the leakage proportion during a time frame of about 12 hours during daytime and nighttime. So it is clear that in this part of the slide a significant amount of leaks increase, and therefore this may eventually explain why we got some problem not only in gas exchange but also in the pressure development. When I finish with a very interesting study by Manuel that is just in front of me, just read the title, Effect of Leak and Breathing Pattern of the Accuracy of a Tidal Volume Estimation by Commercially Owned Ventilator. That was a bench study, but very clarify an important message. The software of the tested NIV ventilators, not only one, underestimate the actual tidal volume. And the greater the leak, the greater the difference between the estimated and the actual tidal volume. So you need a very nice algorithm and very nice software to compensate when you estimate tidal volume from the leaks that you may have. So when you buy a ventilator, you need to be sure that you buy a good ventilator just to try to avoid this problem. Last, a good synchrony. Oh, I ran out of time, but this is matter of another talk. Thank you very much.